This meeting is being recorded.
So I think we're really lucky to have Emily Buckingham here today. She's new to the Valley. She's a primary care provider, primarily working out of Brewster, I think. Is that correct, Emily?
Yeah, half time in Brewster and half in Omak.
Okay. And she's going to share with us some thoughts and about health screening, which is a very confusing topic, I think. And give us her perspective on this as something for us to consider. And I will let you, Emily, do a little bit more of an introduction about how you came to the Valley or whatever you think is important for us to know about you.
Yeah, absolutely. Let me go ahead and share my screen, and then if you all can give me just a heads up that came through.
Yes, perfect.
Okay.
She's a nurse practitioner or a PA. She's not a doctor. I can tell by her demeanor.
I am a PA. So yeah, thank you all for having me. I am a PA, work for Family Health Centers in Omak and Brewster, and moved to Twist in 2021, most recently from Boise, Idaho, and grew up in a rural town in Idaho before that, and moved up here with my husband and pets. My husband had worked for Outward Bound for a long time, many seasons prior. So the Methow Valley was kind of always on our radar as somewhere that we thought we might want to try and get to once we were ready to settle after school and other life changes. So prior to medicine, I worked as a high school teacher for a number of years. And I think there's a lot of similarities between teaching and studying medicine and practicing medicine. And I think both kind of my favorite parts of both, which is that both have and require continuous learning. And one of the things that I continue to learn, and I think this presentation is a good example of this, is that the only real constant in medicine and best practices and recommendations is that they're always changing and evolving, which, like Betsy said, is great because we want to evolve as more research and information comes out, but it's also really complicating because things that we might have heard in the past or done in the past change, and some things go away and new things come. And so I think the challenge of knowing where to look for information and then how also to apply it to each of us, because we're all individuals and come with, various histories, both for ourselves and in our families. So I think just as a quick disclaimer, I'm not here on the behalf of Family Health Center, and we'll kind of run through a bunch of medical recommendations per the guidelines, but I don't want anything that we talk about today to take the place of having conversations or meeting with your primary care provider. I think those things are so individual and so important. So I can hop in if there's not any questions from here. I think Tracy is going to keep an eye on the chat for me. So if anyone has questions throughout the presentation, feel free to type them in the chat. I'm happy to stop throughout, the presentations will probably be about 25 or 30 minutes. And then there'll be a bunch of time at the end, both to show some of the resources that we talk about, but also to answer questions or have discussion. So yeah. Anything before I hop in?
I'll just like to reinforce that Emily has requested several times that she hear from all of you about what things you're interested in knowing about and what areas are important to you. So please don't be shy about raising your voice, and either through the chat or through your hand.
Perfect. Sounds good. So I think first, just a couple learning objectives for the day, hoping that we can get out of where screening recommendations come from. which seems like it should be simple, but isn't always. Which tests are reasonable to consider, and then what we can do both as patients and providers, I think, to make this process a little bit better, or feel a little bit more manageable. And kind of just to start us out, I want to run through a couple of terms that might look familiar to you, but I think will be helpful to be on the same page as we start to run through more of the specifics and how we think about decision making. So oftentimes screening recommendations are developed looking at risks or harms of different tests versus the benefits that might come out of running those tests. And the following are some of the things that we need to consider when we're deciding about testing, and also how to prepare for potential results. So any test that we might be choosing to do has the potential of coming up with a false negative. So a test result which incorrectly indicates that a particular condition or attribute is absent, when in fact it's positive. So an example from our recent world is if you were to take a COVID test and it comes back negative, but in fact you do have COVID and maybe you test positive a couple days later, that first test would have been a false negative. A false positive is a test incorrectly indicates that a particular condition or attribute is present. An example of this is you get a mammogram and potentially the result says that there's a suspicious nodule, or it's a positive screen, when in fact that nodule that they saw on imaging is benign or negative. So that would be a false positive. The problem with both is that either can cause harm. So the harm might be when you thought you didn't have COVID because of the false negative, you went to the grocery store, you went and saw friends, but you're contagious. Or harm might be with the suspicious nodule that then you're anxiously awaiting the day that you go in for additional imaging, and or you need a biopsy, and then there's potential complications from that biopsy, whether it's pain or bleeding or infection. And every test that we have, unfortunately, has both of these things as chances of things that might come back. And then in kind of going through this presentation, I realized that oftentimes the statistics on how common a false negative or a false positive is sometimes really difficult to find. And so I think that's a place where it's always reasonable to ask your PCP and try to find that answer if you're making a decision, but it's not the most readily available, unfortunately. And then other terms that come up when we're looking at screening are morbidity, so the condition of suffering from a disease or condition, and mortality, or the number of deaths due to a specific disease or medical condition. With screening, we're attempting to decrease both the suffering and death from certain conditions, but we might not always screen for something if getting a positive result will not change those two things. So if screening and knowing that there's a positive will not decrease morbidity or not decrease suffering, or getting a positive, but that positive is not going to cause more death or cause death for a patient, then we might not always think that screening is relevant or as appropriate. And so that can be really dependent patient to patient, and oftentimes is part of that conversation or the recommendations that are given. So where do screening guidelines come from? I think it's nice to know a little bit of the background for where all of the various recommendations come from. Why sometimes it's helpful and sometimes it adds to the confusion. So above, I've provided some, but not all, of the organizations that provide us with recommendations. I added you because based on the guidelines, it's very possible that your family history or personal history or preferences might change which guidelines should be followed or need to be followed and which do not. And then I added your provider because based on the varying and sometimes conflicting recommendations that are provided from different sources, your provider might be practicing following one set while someone else down the hall or across the street is practicing using a different set of recommendations. And we'll talk a little bit more about this in one of the examples coming up, but I think some of those discrepancies can feel like they add to the confusion, but I think the reality is it's always an opportunity for a conversation if you've heard two different things or been recommended two different things. So to break this down a little further, I think it's important not only to know what the organization's providing the information is, but also what the goal of that organization is, because that goal is often the driver in how those recommendations might be given. So the USPSTF is often seen as the leading group that is synthesizing research and developing standards around what screeners should be given and why. I think interestingly, it's an independent volunteer panel of national experts, and these volunteers come from different specialties. But they state that their goal is to work to use evidence and research available to help people make informed decisions on screening for disease prevention. And one thing they often put at the forefront is they weigh the potential risk or harm of a screener with the potential benefit in order to kind of weigh that recommendation. The American Cancer Society is another one of the organizations that I found that has pretty clear screening recommendations on a lot of the various topics. And sometimes they differ from the USPSTF. So their mission statement is as follows. The American Cancer Society is the leading cancer fighting organization with a vision of ending cancer as we know it for everyone. And so I think, the goal there was interesting to me because if your goal is to have as few cancers or no cancer, then you might have more strict guidelines and you might be willing to screen more people and take the risk of having many more false positives in order to catch a couple more cancers. And we'll kind of, this will come up in a couple other places. So an example of this, and this came out of an article from the American Family Practice or American Family Physician that compared two groups of women for mammography screening for breast cancer. And they looked at 1,000 women who were screened from age 40 to 74 versus 1,000 women who were screened from age 50 to 74. And so that first group, the 40 to 74, were screened for 10 additional years. And because of that additional screening period, when they compared the two groups, that 40 to 74-year-old group had one additional breast cancer diagnosed that wouldn't have been otherwise. But with that, there was also 576 additional false positive screens and 67 additional unnecessary biopsies. So biopsies of things that came back as benign. And I think this is a nice illustration of the way of risk and harm versus benefit. And we probably all look at that statistic or the way that they synthesize this information, and we might have very different responses. Like some of us might be like, yeah, I would want to start screening earlier in order to potentially catch another incidence of breast cancer. And others of us might say like, yeah, like that's just not worth it for all of the other things that came with it. And I think for me, it's not to say that one is right or wrong, but I think sometimes having a little bit more information can sometimes help us in our decision making or our priorities. And then a couple of the other ones that come up and I've listed are like the American College of Obstetrics and Gynecology, the American College of Radiology sometimes will have their own guidelines. And then some of the specific guideline topics also have organizations that focus on these. So yeah. I am going to mostly in this presentation focus on the USPSTF. One, because Medicare and other state insurances use the recommendations from the USPSTF as the standard for what screeners will be covered. And then I also think that they have a very navigable website that's both for patients and providers. And they try really hard to allow for easy access to the primary research that was used in order to make up their recommendations. And then they have a pretty simple scoring system that I think is nice to look at how good the research is or lacking the research is that makes up those recommendations. So I I put this in slightly simpler terms than that last table. The screening types are broken up into A recommendations, B, C, D, and I. So A recommendations, they like benefit outweighs the harm. And there's quite a bit of evidence to say that. B recommendations, also very clear that the benefit of a screener is it outweighs the harm, but has a little less evidence, and that just might be the research base that we have. C recommendations start to be a little bit more like gray. It's kind of uncertain, or there's a potential of small benefit, but we're not totally sure how much. And anything that has an A or B recommendation should be a screener that we're offering to patients. So that's a little bit of the differentiation. D rating for recommendation is that harm outweighs the benefit. So, and that's pretty clear. We have enough evidence to say that, so should be discouraged. And I recommendations are somewhat more difficult, I think, to understand, and sometimes topics are given I ratings because there's not enough research or evidence on a topic. And then other times there might be a lot of evidence and research available, but if that evidence or research is conflicting from one study to another, then sometimes the USPSTF will also give that an I rating.
Emily, hi. I know I was having technical difficulties, so I just took my screen off, but there's a couple of questions in the chat. One is testing for ability to drive in old age. Would you be able to make recommendations to the Department of Licensing? So that's the first question. And then
Okay.
What are the recommendations for what age group are pap smears recommended nowadays?
Yeah, great questions. I will answer the second one because I don't have pap smears actually in the presentation specifically. And I am not sure about ability to drive in old age, what the best like course of action in terms of where to send people. I would need to do a little bit of looking into that. For pap smears, the recommendation nowadays, and they are changing. So this is another conflicting one, similar to a couple that we will cover. We have ones that say start at 21 and ones that say start at 25. And then, but we're pretty standard in terms of for women without additional risk factors, we screen from until 65 for pap smears. And so if we can stop screening at 65 if a woman has not had a positive pap test or an uncertain pap test in the last 10 years. So there's a couple different tests that we now use for pap screening. One is just a normal pap smear, cytology, looking at the cells of the cervix. And those we do every 3 years. So you would need 3 normals before you were 65 in order to stop at 65. And then the other one, it uses pap screening and looking at HPV or human papillomavirus, or you can just do HPV testing alone to see if HPV is present. And you do that every 5 years if you haven't had a positive. And so you would need 2 negatives for that to stop at 65. Those things always take with a grain of salt if you've like had high risk cervical cancer or high risk cell changes in the past. Those can change those recommendations for when you stop, but for normal 65.
And then one more, my question is if there's a reliable test for plaque and the risk of stroke.
Okay, I'm going to save that one till the end because I think that one will be good to look at together on the USPSTF. But we will remind me to come back to that when I get there. Is that okay?
Yeah, great. Thanks.
Yeah. And you can still see the slide show. Is that right?
Yes.
Okay,
yes.
perfect. So I wanted to start with breast cancer screening. I think it's a good example of when there's a lot of conflicting recommendations from various reputable organizations. So the USPSTF has a B-rated recommendation for 50 to 74-year-olds that they should be screened biannually or every other year. So pretty good evidence, and definite benefit outweighs the harm. There's a C recommendation for 40 to 49-year-olds, should screen biannually. And then there's an I rating for greater than 75 years old. And I think we'll talk about that a little bit. So insufficient data, but great opportunity for a conversation. And then for the ACS, or the American Cancer Society, they break it down a little bit further. So 40 to 44 should have the option to start screening every year. 45 to 54 should get mammograms every year. And then 55 and older can switch to every other year, or can continue to choose yearly mammograms. And then the way that they state it is that screening should continue as long as a woman is in good health and is expected to live at least 10 more years. So I think the screening until 10 more years, or 10 years of life expectancy, is interesting because it is a way that comes up often in the discussion of when screening should stop often. I think it's a difficult thing to know as a provider, how long a patient is going to live. And sometimes it's a really complicated conversation to have. But I think it's the idea behind it, and I think a little bit more loosely, not exactly in the 10, that it's an example of morbidity and mortality for patients. So the example I came up here for this is like, if a patient was dying from heart failure, it's pretty unreasonable to have that same patient be screened for breast cancer. If she's dying somewhat soon. We might find that she has breast cancer, but it's not going to affect her outcome, and it's probably going to add quite a bit more stress. That's unhelpful. And so I think and then that's like in contrast to someone who's maybe 75 and in great health, who maybe if they do find breast cancer at 75 and are able to treat it, they might have another 20 years of great quality of life. And so having that conversation can be helpful. And then the American College of Radiology recommends starting at age 40 and continuing screening past 74 unless severe disease limits life expectancy. If any of you have had mammograms done in the county here, your report, if it comes back as a benign mammogram or a normal mammogram, will recommend that you screen annually, which I think often brings up confusion. I have a lot of conversations with patients because providers have said they can screen every other year, and then they get this report back that says to screen annually. So that I think is always nice to talk through on why those differ. For colon cancer, the USPSTF breaks it down. So an A recommendation for 50 to 75, B for 45 to 49, and then a C recommendation for 76 to 85. And then the American Cancer Society starts screening at age 45, continue till 75. So pretty simple there. A common question that comes up for colon cancer is what's the best screening option? So in simplest terms, it's stated that whichever test that a patient will actually perform on the correct screening interval is the best test. So if they're used the way they're intended to, they all have great outcomes, or benefit outweighs the harm. However, I think making the decision can be kind of complicated and person specific. So I was going to run through these just because I think it also gives a good example. So for screening options, we break it down into stool-based tests. So fecal occult blood tests, or FIT tests, fecal immunochemical tests, every 1 year, versus direct visual tests, CT colonography or flexible sigmoidoscopy every 5 years, or colonoscopy every 10 years. And obviously those intervals are based on getting negative results. So stool-based tests, you collect samples directly from your feces Sometimes people hate that. Sometimes people don't mind it. The test is quick and non-invasive. You don't have to do any bowel prep. And if there's an abnormal result, then we follow up with colonoscopy. Direct visualization tests see direct, inside of the colon and rectum. The sigmoidoscopy is slightly more limited in its visualization. The colonoscopy and CT colonography visualize the entire colon. Colonoscopy and sigmoidoscopy, so and then an abnormal result also follows up with colonoscopy. A couple things that can maybe might change decision making here. Colonoscopy every 10 years or colonography every 5 years has been shown to have a greater estimated life years gained than sigmoidoscopy every 5 years. But colonography, we take images from outside of the abdomen. And so whenever we're taking images, there's a chance that we find other things outside of the colon that we weren't looking for, but might look suspicious. And so we have to follow those up with other imaging or other intervention. So one of the potential follow-ups to know about. Colonoscopy requires anesthesia. So having transportation home and the recovery time following a colonoscopy, one of the pieces there. And then with colonoscopy and sigmoidoscopy, both have very small risks, but risks of bleeding or perforation during the examination. So I think you run through all of those and people might have very different desires on which might fit for them. Within FHC, I've only ever seen the FIT testing and the colonoscopy screening used for colon cancer. I don't know if we have CT colonography in the county, but I haven't seen it be used. And then another argument for which testing, some people will say that annual FIT testing places less stress on the system just because we don't have very many providers who perform colonoscopy. So leaving those slots for colonoscopy for symptomatic patients or for positive findings is helpful. I don't think there's a right or a wrong necessarily, but I think it's a great example of why sometimes more options adds confusion or adds necessity for conversation. And more information allows patients to make a more informed decision. So with osteoporosis, the USPSTF breaks it down an A recommendation for falls risk screening. So recommending exercise interventions to prevent falls, which I think is a nice recommendation just to remind us that if we can decrease the risk for falls, we're going to decrease fractures. And then a B recommendation for osteoporosis screening, both in postmenopausal women 65 years old and older, and then postmenopausal women younger than 65 at increased risk for osteoporosis. And then the American Geriatric Society follows the USPSTF, but further breaks it down a little bit in terms of what does it mean for those younger women to be at increased risk. So they state that if their 10-year fracture risk is equal to or greater than that of a 65-year-old white woman without any additional risk factors, then we should be screening them. And I saw this in a couple different places, both in the USPSTF and in the American Geriatric Society. That risk for a 65-year-old white woman without additional risk factors is somewhere in the realm of 8.4 to 9.3% for their 10-year fracture risk. So I can show you how we might use this. And let me try to do this real quick.
Oh, you've been muted, Emily. You'll have to do the go back.
I think I did it. So you can, and now you can see the calculation tool.
Yes.
Okay.
Yes.
So this is something, it's free, it's available. The fracture risk assessment tool is one that we can use to calculate the 10-year probability of fracture. so Tracy and I were talking about this a little bit yesterday, and Tracy, if you're still willing to be my example, we'll kind of just see how it can be used to decide on screening.
Sure. Yeah. Or if someone else here is interested in seeing for themselves, you can go ahead and speak up. Sheila.
You could test the system by testing me because I have osteoporosis. So I might be, unless somebody else wants,
Yeah. So once someone has osteoporosis or known osteoporosis, we're no longer looking at screening for osteoporosis because we have that answer. But
Okay.
Sheila, did you find out that you had osteoporosis through a DEXA scan or through a fracture?
No, DEXA scan.
Okay, so that was a perfect example of the screening for osteoporosis.
Yeah.
Okay. Yeah, I'm happy to.
Okay, yeah, or I'd do it too, if you want somebody.
Okay.
I can't, can
Sure.
you make that bigger? That,
How's that? That's as big as I can make it.
Oh, yeah.
get out my magnifying glass. You'll read the
Well,
question.
Emily,
You read the questions, I'll answer.
Okay, if I can get your age
74,
and then your date of birth.
8/7/1948.
Okay, and then your weight.
175.
Okay, which is in kilograms, somewhere around 80. And then height,
5'3".
and I think that is right around 160 in terms of centimeters.
I'm glad this isn't one of those BMI tests. Of course, I already know that.
In centimeters. Let's just make sure I'm right. Oh yeah, 160. Okay. Have you had a previous fracture?
No,
And did either of your parents have a fractured hip?
no,
Are you a current smoker?
no,
Are you taking glucocorticoids or steroids on a daily basis? Do you have rheumatoid arthritis?
no,
And do you know that you have osteoporosis?
no,
And do you drink 3 or more drinks for alcohol every day?
no,
Okay. And have you had a DEXA scan?
yes,
Okay. So we could, if we had your DEXA results here, we could put your DEXA result here for your bone mass density, and it would be a T-score that usually comes up there. But we don't have that in front of us. So we'll just calculate it. So per this tool, it would say that your 10-year probability of a fracture would be 12%, and a hip fracture is 2.9%. But let's pretend that we go back in time 10 years when you were 64, and you're trying to decide if you're going to wait till you're 65 and you should start screening, or you're okay to wait that additional year. And so calculate it there, that risk changes. You're a 64-year-old without any of these risk factors, and based on your weight and height and sex, you have a 7.6% probability of fracture in the next 10 years, and a 0.8% for a hip fracture, which
and you went back 10 years?
I went back 10 years.
Yeah, okay.
Yeah. So if you were 64 and trying to decide if you should start screening sooner than that recommended 65 years old.
Mhm.
And what we would see here is that, like, no, the recommendation would say it's not necessary for, like, recommended to start screening early because your risk for fracture is lower than that average risk. So kind of a nice tool to help us
Yeah.
in decision making.
Yeah.
I think it's not, we don't always have to say like yes or no, or but it's nice information.
I think, to make some kind of chart where you put in, if 10 years ago I had used this tool and then put it in, and notice at some point, maybe you say, okay, now I should start screening. Of course, that might be what your provider does too.
Yeah, we tried to. And I think we do in certain instances use, a lot of different calculators like this to help us in our decision making. I think sometimes it's nice as patients to know what is going on in the behind the scenes. And so sometimes like pulling out a calculator during a visit and running through this with the patient and then being able to show them can be really helpful. Then it's not just us spouting numbers, which isn't always as helpful.
Okay, yeah, Emily, you'll have to go back and
Okay.
there you go.
Perfect. Thanks, Tracy. So a couple things that we don't see here that we did see in prior recommendations is we don't see any sort of screening interval. And that is mostly because we don't know what the right screening interval is. On the USPSTF, they note that there's a couple studies that have looked at screening intervals like 4 years or 8 years after the first DEXA scan. But there really isn't a clear benefit to that that's been shown. And so we just don't know yet how we should be going forward with that at this point. So
I just realized my weight was recorded.
Oh, that's okay.
I'm just kidding. All of a sudden, I just thought, oh yeah, this is recorded.
Oh, thank you for being brave.
Yeah, transparent maybe.
Yeah, there you go. So next one is skin cancer. I just think is a common question. Per recommendations, it's an I, so insufficient to assess the balance of benefits and harms of a visual skin examination. And remember, this is for adults with no additional risk factors, so an average risk asymptomatic patient. The American Academy of Dermatology also has no formal guidelines, but they do encourage members to hold free skin cancer screening events. So that's something they do provide. I think when I was thinking through this.
Wait a minute. Where are those? I just called
I know.
appointment and I said, they say your time period. So it was, I said, oh, in the next month. And they gave me an appointment in November. And I wrote back and said, was that a typo? November? Anyway, where can you get these free skin cancer screening? That sounds cool.
I think, this is new to me, but I think when I was looking at the American Academy of Dermatology, they have some information on their site in terms of where screening might occur. My guess is that it's in Spokane or Seattle, or that, we would need a dermatologist in the area to put one of these on. So I don't know.
Okay.
It might be one of those things we don't get in our rural corner of the world.
Maybe we can bring it in. Yeah. I can't tell you how many people would line up.
Would want that. Totally.
Yes.
Yeah.
Yeah, that's a great idea.
The skin cancer screening, and I think that, like the eye recommendation, we just don't know is sort of, it brings up a question, because I think a lot of people do want skin cancer screenings. And so I think this is a great example of how recommendations are written in terms of leading to mortality or morbidity. So like basal and squamous cell carcinomas are the most common types of skin cancer, but frequently lead to death or morbidity or suffering or symptoms, versus melanoma causes the most deaths from skin cancer, but it represents only 1% of skin cancers that we find, 1%. So the USPSTF had that, they estimate 8,000 individuals in the US will die from melanoma this year. So I think it like comes back to, if we're not changing morbidity and mortality enough in people without additional risk factors, then we might not screen everyone. That being said, I think this is a super important one for like personal history, family history, for patients who notice changes or new skin lesions. Like you can always ask for a skin check from your provider. Doing a thorough one takes time. So like sometimes setting aside a visit just to focus on that can be really helpful. But it's something that is like absolutely reasonable to ask about, or ask to have a conversation about what your risk factors are. And so if you should have a skin check. And then the last kind of bigger topic that I wanted to run through before we kind of go through a bunch of little ones is screening for depression. So there's a B recommendation for screening for depression, and then they add, with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. And I think that this is a really nice reminder that we can't just screen to screen. So if we are asking people questions about depression and symptoms, but not going to be able to support them or provide treatment, then knowing that they have depression doesn't really help us. And it certainly doesn't help their morbidity from depression or increased mortality from depression. But if we're able to offer treatment, then we can decrease the morbidity and mortality of depression. And we know that if left untreated, depression can be associated with increased cardiovascular events, exacerbation of comorbid conditions, change relationship with pain and suffering. So having both the screener and then the follow-up. And a couple of the screening options, like this might look familiar to you all from clinic. We can sometimes do a PHQ-2 or a PHQ-9. The PHQ is the 2 questions, little interest or pleasure in doing things over the last 2 weeks, or feeling down, depressed, or hopeless. And then it's rated on a scale, a number more than 3, or 3 or more, kind of is a marker for us to do a little bit further screening or have a conversation. There's really no evidence on how often we should be doing these. I think in our clinics, we try to do them once a year. And then in terms of intervention, that could look like medication, that could look like counseling or psychotherapy, together or alone, can talk about increasing physical activity, things that we know that impact depression. And then when I was looking at there's the National Institute of Aging, talks about depression and just how important it is to screen as people age, which I agree with, but also thought was interesting as they listed a bunch of the factors that can contribute to depression. And I think often these factors can be more prevalent as we age. So some of those things included increased medical conditions, sleep difficulty, social isolation and loneliness, lack of exercise, and then changes in functional activity or having functional limitations. So not being able to do the things that we like to do during the day or our activities of daily living with as much ease. And yeah, so I think having this on our rate's a good one. And then
There's a couple more. Oh, sorry.
Questions?
There are a couple more questions in the chat here that I want to make sure that just leave time for. So
We are very close.
okay,
Yeah.
great.
Okay. Yeah, so a couple other things that providers might bring up: HIV screening, one-time screening from 15 to 65, hepatitis C screening. This is a new one that's kind of changed. It's changed recently, I think in large part because our treatment for hepatitis C has become much more accessible and with less side effects. So wanting to know more. Unhealthy alcohol use, unhealthy drug use. abdominal aortic aneurysm screening. So one-time screening for men 65 to 75 who have ever smoked. Screening for diabetes or prediabetes in asymptomatic adults, 35 to 70 who have overweight or obesity. And then prostate cancer screening. I don't think we have any men on the call, but this is also a screening that has changed more recently. And so some of the information around that is really geared towards shared decision making with providers and patients and based on history, and I think is a nice example of that. And then just to wrap this up, so I think kind of like what can we do to make these things better? I think a couple takeaways is that like change is the only constant. So the USPSTF tries to review recommendations every 5 years to see if new evidence has arisen. And so being open to the fact that something you might have screened for in the past might no longer be recommended, and vice versa. There might be new things that are coming up. One thing, I was talking to some of my colleagues, and our electronic medical records, or our EMRs, will often send patients notifications that they're due for certain things when they're not. Sometimes it doesn't pick up that a test has already been completed. And so that can be confusing when you get a reminder in the mail that tells you you're due for things. And I'd say just like use those reminders as an opportunity to have a conversation with your PCP. And then I think clinic culture is a big difference too. So if all of my colleagues were recommending mammograms every year and I was recommending them every 2 years, that might be really confusing for patients and not make it so that care feels very constant or consistent when a patient sees another provider. So I think sometimes people will change their practices to align more similarly with their colleagues. But also there's a reason that one provider might share something different than another. And we all have different ways that we think about things. So always asking questions on that is reasonable. And then the variation. So being willing to look at a couple different sources, I think, is also nice. And then one plug for overcoming is the Medicare wellness visit. It's like kind of our annual visit that's not aimed to focus on anything acute or new or happening in the moment, but to review your goals for your health and review screening options and then identify needs, which I think is kind of an unsung visit. I don't know that many patients like their Medicare wellness visits because sometimes it doesn't feel like things are getting done. But I think it is a really helpful moment in medicine where our only goal is to go through those things with patients and hear from you all what's on your mind. So those were kind of my plugs. And now, yeah, let's go. We can kind of hop back over to the questions. Betsy, I saw your question about insurance coverage for screening colonoscopies. So because of the USPSTF recommends any of those screening tests that we went through as an A or B recommendation. And so A and B recommendations are covered by Medicare or state insurance. And that's just how it aligns. So they should cover any of those options for screening. And I think if we go back to the colon cancer, so what might make it complicating is the C recommendation for ages 76 to 85. And that is probably insurance dependent. And that might make a very big difference in terms of how a patient might want to screen during those years, where like a FIT test, something you take home and send to the lab, is going to be very different than a colonoscopy in terms of cost. But it's a cost that you might need to take annually if you're really going to try to follow those screening recommendations, versus maybe you do a last colonoscopy at 76 and you decide that's worth it to you, and that gives you 10 years of reassurance. So that would be kind of thoughts on that.
So we've had a couple of people here in the valley who have had strokes, and I just wondered. And there's something at the barn that says for $170, they'll do some tests. But I Googled the reviews on that and they weren't good at all, because they say they don't match what your doctor is looking for. So you're kind of, it doesn't benefit you. But is there some kind of test for any kind of, for plaque in your bloodstream?
Yeah, so I think those screeners, are those the Lifeline screeners?
Yes.
Yeah.
Yes.
Those are new to me, but a provider in the Meta was just telling me about them. So I think they do an EKG. So they do like a quick rhythm strip for your heart to look to see if someone has atrial fibrillation. And then they also do I think it's a calcium score. She was telling me about this, and I was looking, and I think all of the things that are a part of that Lifeline screener come in as like a C recommendation or below, and we can pull that up right now if that would be helpful. Let's go.
Well, I was just curious. Before I ever heard about that, I had that thought, like, well, why not have an MRI just to see if they see anything?
Yeah.
Is there such a thing that's, maybe, I don't know, or do people ever schedule MRIs when they have nothing?
No, and mostly going back to that idea of, are we about to find something that is never going to cause any problems, but it's going to make for a lot more follow-up and potentially a lot more anxiety. So, I mean, we could do an MRI of your head, but maybe we see a couple little spots in your brain, and all of a sudden we send you home thinking that you have brain cancer.
Yeah.
And then we need you to go do, 2 other scans and meet with a neurosurgeon. And all of a sudden we've cascaded on some changes that you would have never had symptoms from. And so the screening for plaques in your carotid arteries is not recommended as long as a patient is asymptomatic. So not having symptoms of that. Of course, in terms of stroke risk, like there are other things that increase people's stroke risk, whether that's diabetes, whether that's high cholesterol, and we do screen for those.
That's true. That's true.
Yeah.
Okay. Thank you.
Yeah.
Yeah, and there's a few more over here. Sheila, I'm 69. Is there a list somewhere of the standard?
Yes. So the best place that I have actually found it is the USPSTF has an app. And they have an app, and you plug in your year, like how old you are, what your sex is, if you're a tobacco user, and if you're sexually active. Those are the 4 questions that it asks from you. And then you can like click start, and it breaks it down into all screening recommendations for your age.
USPSTF?
And that's,
thank you.
Yeah, that's what the app is called. And that's the organization that we've kind of run through on all of these. So you search it, and I mean, it really does it comes up in a really like navigable way. I think you can then on the top of that app, once it gives you this huge list of things, you can break it down into A and B recommendations. So that would be that list of things that you would want to consider. Again, like any of these screeners are for average risk, asymptomatic people. So like it will give you an osteoporosis screener for you, Sheila, and you were talking, you have osteoporosis. So that would not be relevant for you, but it would at least be a great starting place. And then you can also look at C recommendations or D recommendations or I recommendations.
Thank you.
Yeah.
And
I wish there was an easier way. There should be.
I don't want to be rude, but I have to leave. I have an appointment. So thank you for this very much. Bye-bye.
You're welcome.
Sheila,
Yes.
I would love to talk to you.
Talk to me?
Yeah.
You mean sometime?
After I'm, yeah.
Okay, 509
Okay.
341 4111. Okay, I gotta go. See ya.
Bye, Sheila.
And then there's, yeah, just a couple from Sue over here in the chat, if you can.
Yeah. So to combine a couple of the previous questions, there's standard list of Medicare insurance covered tests aside from ongoing diagnoses that should be
Kind of
addressed.
answered that more or less.
Yeah, I mean, unfortunately, I wish it was easier. Like, it seems like those things should be almost like auto-populated for us to run through, and they're not. I mean, I think our electronic medical records try to do that for us, but they don't do it super well all the time. But yeah, I think probably different providers do it different ways to kind of keep ourselves on track. And then certainly the list there is is a reasonable thing to kind of run through. And then addressing depression, are we considered an area to have adequate coverage? Answer yes. Yeah. So yes, if someone screens positive on a depression screener, like, we should absolutely be addressing that during the visit, at least enough to know if it's something that we need to address in the moment or if it's something we can schedule a follow-up on. I think it's like always, yeah, if we're gonna screen, we need to know that we're going to be able to address if it comes up as a positive. I don't know about the area having adequate coverage. I feel so grateful in terms of my work at family health centers. We have a really strong team of behavioral health specialists, so some counselors, some social workers that I have in the clinic with me on a daily basis. And so if someone screens positive on a depression or an anxiety screener, I will often have one of our behavioral health specialists come into that visit and do what we call a warm handoff. To one, even just I think check in terms of how they're doing, how urgent is this, give them information about the resources that the clinic provides, set them up with an appointment in the moment if that's something that the patient is interested in.
Well,
Before I do, go
I
ahead.
thought in your slide on that, Emily, the lead and things said if your area where you live has adequate coverage, then we go ahead and do it. So do we have adequate coverage? Or yeah, the slide was something like that.
Yeah, so I think the wording on it was screen for depression with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up.
Right.
And I would say in my clinic system, yes, I have that.
And there's
I don't.
Zoom.
What was that?
Well, there's Zoom. In the old days, if you needed a provider to help you with depression, a lot of times our area was so overloaded and understaffed. But now we can do stuff on Zoom. So I can't imagine any area saying, over our computers.
Yeah. So I think one thing our area lacks is our providers who are specialize in mental health. So psychiatric nurse practitioners or psychiatrists.
Yeah.
Our area is really limited in that area. There's one nurse practitioner currently at Okanagan Behavioral Health Center, and they are basically triaging the things that need to be seen most urgently for her to be able to help with management. Primary care providers should be able to provide most of the information and first couple options for treatment for something like depression or anxiety. Of course, if there's something more severe in terms of mental health needs, that's where those referrals, then we need to have those referrals. And that's not always something that I feel like we have a lot of support in our county, and sometimes does go to telehealth or sometimes requires travel.
And often isn't covered by insurance.
Yeah.
Oh, true. Huh.
Yeah, I've had a couple of patients recently I've referred for like a child psychiatrist, and they do not take state insurance. And so that is like that's a huge hole, I
Wow.
think, in terms of yeah, patients that with great need who yeah, we're not totally sure where to send them for help.
Wow.
Emily, you've been.
Okay.
Yeah. Tracy, are you frozen still or not?
No, I am here, but yeah, Betsy, if you want to do the little wrap up with Emily, that was excellent, Emily. Thank
We
you so
really,
much. I think
appreciate
it's fantastic to have this information recorded and that we can share again.
Mhm.
And what a great resource. Let me make sure I have it right. USPFTF?
USPS, United States
Yes.
Preventative Service Task Force.
Okay, there we go. I'll make sure to definitely share that information, and so folks can look on there.
You didn't talk about a test for Alzheimer.
Yeah. That's a great question.
Yeah.
Yeah.
Is that coming?
Is that coming? I wish. That would be, I mean, that would be helpful. I think, I mean, I would want to look and see what I didn't look into that specifically. I think oftentimes, and maybe this is me personally, but sometimes I feel like we will screen for like mental, like cognition or mental function, and not always know what to do when we get a positive, or not always feel like we have resources when we get a positive. And so that's a super tricky one. And I'd be happy to look more into it and send you if I find some things.
Okay.
Good question. Yeah.
Well, thank you so much. And we may tap you again.
Okay.
If
Really, that was
any
great.
of you on the call have other additional questions you want to bring forward, we can try to get some answers to them as well. I think, and we continue to work on resource lists for this kind of being your own health advocate, so that you know what you want to ask your primary care provider for when you go to see them for your Medicare wellness exam, and make sure that the things that you are most concerned about also get addressed. So
Is there somewhere we can access the recording?
yes, on the Meadow at Home YouTube channel.
Okay.
This will be posted probably after a few days. It isn't posted immediately, but it will be on YouTube. You're all famous. You've had your, and feel free to, if you have trouble accessing it, just let Tracy know and she can help you.
Thanks.
Yeah, absolutely. Okay, thank you so much, everyone. Thanks for your questions. Thank you, Emily, for doing that excellent presentation. I can definitely see that you are an educator at heart. So I really appreciate the time that you put into this. And all right, may we all be well.
Yeah.
Yeah. Enjoy the sunshine.
Thank you.
Thank you.
Take care.
Bye-bye.
Thank you for joining.